Welcome, and we're coming to you today from Breastlink Tarzana, which is pretty exciting, especially because it happens to be Breast Cancer Awareness Month. Absolutely. Although, a lot of what we're going to talk about today is important all year, right? Not
Absolutely.
just October. And my guest today is Dr. Jason Mckellop, who is a breast radiologist and medical director here at Breastlink Tarzana. Welcome, Dr. Mckellop.
Thank you so much for having me.
Yes.
I feel honored. This is my first filmed podcast, so
It's very exciting. And I also want to say that Dr. Mckellop is one of my favorite go-to people for information. I reach out to him for blog articles and information.
If I could blush, I would.
Well, so I'm super excited, and we're going to talk about a lot of stuff.
All right. I'm excited. Let's do it.
So I'm super excited. This is going to be sort of like a breast health 101 overview. And I thought it would be cool because for anyone who listens to the podcast, I always am talking about things that I've read because I do that a lot. I start my mornings with a cup of coffee and a bunch of medical newsletters, journals. I'm not a doctor, but sometimes I think I am.
Maybe I should be asking you the questions. You may be the authority on these topics at this point. So.
I might be. So I do read a lot of articles, and some of them we've talked about, but I just thought it would be cool to go over some of these new studies and things I think people should know about, right?
Sure.
So what the first one I want to talk about is something that you and I just have talked about because I did write something about it, and this study really surprised me, and it showed that a large percentage of women who receive a false positive after a mammogram, so they're called back either for a second mammogram or for a biopsy, are not returning to regular screenings.
Yeah, that's a bit of a disheartening statistic and fact to process. I think it would probably benefit us to talk about cancer biology to a degree before we specifically address this issue and why it is indeed so problematic.
Yeah.
So breast cancer has its origins initially from a genetic abnormality, a genetic mutation that happens at a subcellular level. This is invisible to us as human beings. We can't see it on a microscope. We can't see the origin of cancer at its origin.
Right.
And this genetic abnormality then propagates itself into a cellular abnormality and then ultimately into an anatomic abnormality, at which point we can hope to see it on our imaging studies.
Right.
So along that process of genetic abnormality, or that timeline rather, of a genetic abnormality to ultimately developing an anatomic abnormality or a mass or calcifications on a mammogram or an ultrasound, there is a vast degree of overlap in the appearance of normal tissue to abnormal tissue.
Okay.
And that is really the crux of the problem in interpreting mammograms and why we do have false positives. If you have an overlap in this appearance of normal and abnormal, it isn't a binary decision whether or not disease is present or not. I think a common misperception of medicine, and certainly within breast imaging, is that it's a black and white field. Is cancer there? Yes or no? And oftentimes we find ourselves in an unforgiving shade of gray. And this overlap speaks to that shade of gray. So we have to call things back to rule out disease when there are not clear-cut answers present. Right. And this overlap is the cause for false positive results. But back to this timeline. If we are not able to see a mass or a malignancy in a flagrant form where we could say definitively there's disease there, then we have to try to diagnose it as early as we possibly can. And that falls into this shade of gray, or this area of ambiguity that I'm referring to. And in so doing, we cast a wide net to make sure that we don't miss disease that may be present.
Right.
So a lot of the callbacks, the patients that we do call back to scrutinize through diagnostic mammogram and ultrasound may ultimately have benign results. They may be negative exams. There may not be any disease present whatsoever. But we have to do our due diligence to make sure that we don't miss any disease. And in so doing, unfortunately, we call patients back and return them home with these benign results. It's an unfortunate consequence of this paradigm that women may become disheartened and potentially discouraged by this process. And going through it once may discourage them from doing it ever again.
Yeah.
And I think that's what this study is probably referring to, that some women who experience this paradigm of being called back and having a benign result feel that they may never have to have it again. But the problem with that is that very timeline that we discussed at the very outset of this conversation. That slow progression to developing disease is indeed a slow one. It could take years, if not decades. There are women walking around right now with the precursor for disease, and we can't see it on our imaging studies. So the fact that you're called back from an imaging study and it's benign does not mean that you're negative for the remainder of your life.
Right.
There's a timeline with which disease develops, and we have to keep scanning on an annual basis to make sure we catch disease at its earliest time point. So it's a disheartening thing for me as a physician and as a breast imager to know that there are women who are called back and then are discouraged from coming back for future screening, because it really is the repeated process of screening that we're most successfully discovering disease.
Yeah. A report from 2022 suggested that after 10 years of annual screening, 50 to 60% of women can expect to have at least one false positive recall. So it's really common.
Yes.
So,
Yeah. And I think approaching it with that expectation that it is a common phenomena within breast imaging, that one may be called back for a false positive result. Maybe being armed with that information would maybe steel or harden one to the possibility of it.
Right.
But remain encouraged for future screening.
Yeah. I mean, I can understand, you get it. You get told that you have to come back, and then you kind of go through this whole litany of emotions, like you're nervous and, oh, this is it. This is my, and you go through this up and down, and then they tell you it's not. So I can understand that it's,
It's an anxiety.
However, yes.
Yeah, it's an anxiety-provoking exercise.
Yes.
You can't walk into this facility without some level of angst, because the answer or the question that we're trying to answer is cancer there, yes or no? And and that's an anxiety-provoking question.
Yeah, absolutely. And then the other aspect of this that I wanted to ask you about is that another study showed that this study had used a large population with long follow-up that showed that women with a false positive mammography result had an elevated incidence of breast cancer for up to 20 years following that false positive. So
the details of this I'm not entirely certain about, but it's something that has been known for quite some time, that having been called back from a mammogram, there is an increased risk of that individual developing cancer in the long term. And the reason for this, as a breast imager, the reason that makes sense to me is that there is some peculiarity about the imaging study, something about either the woman's anatomy, her breast density, or the features that are on the mammogram that either correlates with this phenomenon of developing disease, or there may be something nuanced about the architecture of her anatomy that may just on a global scale or a population level scale may predispose such patients to developing the disease. Or there may be truly a feature that has evolved or changed within the breast that is positively correlated or positively associated with the disease.
Right.
I would expect some to see this statistic and think, well, perhaps being called back is exposing one to greater, radiation, and this radiation exposure is what is causing disease. I would say that would be a false assumption or presumption to make based on those results. The degree of radiation exposure is so small; it's the equivalent of existing on Earth for 7 weeks. So it's a very low exposure risk, and that in of itself would not be increasing one's risk for developing breast cancer. I think this more than likely harkens to or relates to the anatomy or the visual appearance of the study, and some positive association or correlation between the anatomy, the appearance of the woman's mammogram, and future breast cancer risk.
Right. That's so interesting. So it's like something's not right, but it's not quite identifiable yet.
Precisely.
Right.
Yeah. And perhaps in the future, artificial intelligence or some computer algorithm will find out what that peculiarity is and inform us.
Yeah. Well, we're going to get to artificial intelligence.
Oh, yeah. Let me not jump the gun here.
Yeah. But that's really, so that's like yet another reason not to discontinue the regular screenings.
Precisely. Yeah.
After the false positive. So
yeah, breast cancer screening works best by looking for changes. So seeing those changes over time are very helpful for us as radiologists, and the ultimate pursuit of diagnosing disease sooner.
Yeah. Okay. That was really interesting. Yeah. Next topic. So the next thing I want to talk about is another piece I read regarding 3D mammogram. Otherwise known as tomosynthesis. And this study showed that digital breast tomosynthesis increased breast cancer detection rates and showed invasive cancers with a lower rate of advanced cancers compared with traditional mammography. So basically it suggests that 3D mammogram screening may reduce advanced cancer development.
Yes. So 3D cancers or 3D breast cancer screening through tomosynthesis is one of the latest evolutions in our ability to detect a disease. Yeah. We've gone through various stepwise evolution or progressions, if you will, in terms of our technology and our ability to detect disease. We moved from a 2D world, basically where we took an X-ray of the anatomy and we looked at the anatomy as we would a flat sheet of paper. Yeah. And we evolved into a 3D image. And we can now look at the anatomy or the mammogram as we would a CT scan or an MRI and scan through the images progressively in a three-dimensional or volumetric manner. Right. And that confers a very strong ability or good ability for us to see anatomy, the changes in the anatomy and the subtle features in that anatomy a lot better than we did in our two-dimensional past. So there are certain things that we could see on a 3D mammogram, namely architectural distortions, and some masses that would have otherwise been obscured in a 2D mammogram, and we could see them to better advantage. We're seeing small disease in higher detail and higher resolution than we had in the past. So it's of no surprise that we're seeing disease earlier. We're conferring a survival advantage as a result by seeing disease in a smaller size and in greater detail than we had in the past. Yeah.
And is 3D mammography, is that better for women with breast density?
So women with dense breasts, I would say all women would benefit from having a 3D mammogram. Mm-hmm. The benefits have been shown in terms of cancer detection rates across a spectrum of breast density. Yeah. But the size or the degree of benefit is greater in women with dense breasts than it is in women with less dense breast tissue.
Okay, so we're going to go to, let's talk about breast density then.
Sure.
I'm jumping ahead a little bit, but
no worries.
From my organized outline. But
no problem.
So can you explain a little bit about, I mean, there's a sort of like a big topic, but I want to talk about that. Can you explain breast density?
So let's talk about the breast anatomy. It's composed of two main things, fat and fibroglandular tissue. The fibroglandular tissue is kind of the business end of the anatomy. This is the part of the tissue that has supportive framework or architecture within the breast that supports the structure of the breast. And then it has the glandular tissue, which is responsible for producing milk at the time of lactation. Fat on a mammogram appears black. So x-rays can penetrate fat in a certain way that it exposes a film where it looks black. And fibroglandular tissue looks white. When we talk about breast density, it's merely a ratio of the fibroglandular tissue, or the white, on a mammogram relative to the black.
Okay.
If you have more breast tissue or fibroglandular tissue than you do black, you tend towards the dense part of the spectrum, and more fats relative to fibroglandular tissue, less dense.
Okay.
So about half the population has dense breast tissue, meaning roughly greater than 50% of the anatomy is composed of fibroglandular tissue, and the other half has less dense breast tissue. Why is breast density important? Well, dense breast tissue, when you look across a population, confers a slightly increased risk of developing breast cancer. This shouldn't alarm anyone. Like I said, the majority or half of the population does have dense breast tissue. But if you look across thousands, if not hundreds of thousands of patients, there's a slightly increased risk of developing breast cancer among patients who have dense breast tissue when compared to their less dense counterparts. So that's issue one. Issue two is that when we look at mammograms in dense breast tissue, life is a little bit more challenging for me as a radiologist to interpret those studies because, like I said, or like we discussed at the outset, breast cancer can be very subtle and it can look like normal tissue. And it typically has the same density of fibroglandular tissue. So fibroglandular tissue can mask or conceal the appearance of disease and make it more challenging to discern disease from normal when looking at a mammogram. So those are the two key issues with breast density. Dense breast tissue confers a slightly increased risk, and it makes it a little bit more challenging to detect disease when you do have dense breast tissue.
Do we know why there's this increased risk for women with dense breasts?
I don't think the answer is known.
Yeah.
But statistically speaking, it does bear out looking at a population that there is a slightly increased risk.
Right. So what about? So I know that there's a new FDA ruling about all mammography facilities need to inform women of their breast density following a mammogram.
Yes, the FDA recently legislated that all mammogram facilities need to notify women about their breast density. And this is important for the reasons that we've discussed, but also for women to advocate for their own health.
Yeah.
There are supplemental screening studies, namely breast ultrasound, that can help in the setting of dense breast tissue.
Right.
There's some things that we can see on ultrasound that we may not see on mammogram. So getting supplemental screening does benefit women. And statistically speaking, there's one additional cancer detected by ultrasound across 1,000 patients in women with dense breasts. So statistically speaking, it does benefit women with dense breast tissue to potentially be screened with ultrasound. MRIs are the most sophisticated imaging study in our entire arsenal of imaging. So supplemental screening, especially in patients with a higher risk of developing breast cancer, those with genetic predispositions or strong family histories, may get supplemental screening with MRI as well.
And to determine if you have dense breasts, you can only do that.
So imaging studies are the best gauge for breast density because you can't ascertain it from a physical exam. You can see the ratio that we discussed of fibroglandular tissue to fat, namely on a mammogram. You could glean it from ultrasound and MRI as well, but mammograms are probably the bread and butter screening utility that would give us that information.
Okay. Yeah. I mean, I guess, it's great that that women have to be informed about their breast density. I know in California, they were doing it for a while already. Yeah.
And also in the tri-state area, probably as a consequence of local or state legislation, this has been a mainstay. So it's been in the lay letters given to women in various states along the East Coast already, but now it's a federal mandate. So all facilities have to comply.
Right. Which is great. I mean, because information is power.
Absolutely.
Right?
Yeah.
I mean, I think the one thing is that not all insurance will cover the supplemental screening. Yeah,
I think for the most part they do. I can't speak for all carriers, but for the most part, supplemental screening with ultrasound should be covered for the most part.
Okay. Well, that's good. Because, you know, if you get that information and then you can't do anything about it, doesn't really get you very far.
Yes.
Right.
Yeah.
Okay. Well, that's good. Okay. So I also want to ask you about breast calcifications. Yeah. So explain exactly what that means.
So calcifications are little white dots, like grains of sand or grains of salt, if you will, that develop in the female breast. They're very common. If I were to pluck someone off the street and do a mammogram, I'd probably find at least one calcification in either breast. But we pay close attention to them when they're grouped together in clusters or groups of calcifications. Okay. And the reason this is the case is because it may be the manifestation of breast cancer, specifically an entity known as DCIS, or ductal carcinoma in situ. Without getting into the gory details of the biology of this, suffice it to say that breast calcifications, or these little white dots or grains of sand, if you will, can be a manifestation of cells, cancerous cells that have effectively outgrown their blood supply and have died. So those cells can atrophy and then calcify over time or turn into stone, and they create these little white dots on the mammogram. So they tend to have a broken glass appearance in their classic form, and we look for these calcifications on mammogram, and we thankfully mammograms are the highest resolution studies in all of radiology, so that we could see these tiny, nearly microscopic white dots as a manifestation of this disease.
Interesting. So you're saying the cancer cells die and then they form, but does that indicate that there's thriving cancer cells somewhere hiding, or? So
there are a marker of disease. So maybe we will dive into the histopathology or the biology of it a little bit. So within the breast you have ducts. These are the tubes that are responsible for transporting milk at the time of breastfeeding.
Right.
These are literally tubes that travel from lobules, which are grape-like structures responsible for producing milk at the time of breastfeeding, and these tubes terminate onto the nipple.
Okay.
So within those ducts is where the majority of breast cancers develop. You have normal ductal epithelium. This is what you expect to see in the normal anatomy. And as things progress from a spectrum of normal to abnormal, you grow through atypical cells, which have a different morphology along those ducts, called atypical ductal hyperplasia. And then it progresses to ductal carcinoma in situ. And these cells tend to grow in a thicker fashion. Imagine maybe the wall of a hose developing a bleb or being thickened, and or maybe even a stone getting lodged into a garden hose. That's kind of what happens anatomically on a microscopic level, where these cells start to grow into the lumen of that duct, or into the bore of the duct, if you will. So once those cells start to thicken the wall of the duct, they need blood to grow. But because it's a cancer cell and it's growing abnormally, it can outgrow that blood supply and get so thickened to the point that the little blood vessels that are feeding it can no longer reach it. So the cells on the periphery of that growth, that mound of growth, if you will, no longer have a blood supply, so they die, and it's a process called comedonecrosis. It's a fancy term for just describing death of a cell.
Okay.
And those cells lose their blood supply, and then they harden, they atrophy, and then they turn to calcium or stone over time. Because they're trapped in such a small part of the anatomy, those cells, after they calcify, tend to develop this broken glass appearance that I'd mentioned, and they tend to elongate along the duct. So we could see them in a specific distribution, kind of a linear and sometimes segmental distribution, outlining the anatomy of the ducts. And in so doing, typically things don't really pan out in a textbook fashion. Like I said, there's an overlap between normal. So we do see calcifications that are benign that overlap with this appearance. Right. But we try to diagnose it when we see those classic features of it.
Yeah.
And that's why calcifications are important, because of that process, because of this very convoluted, maybe more information than you care to know.
I love it. I think it's fascinating.
Yeah.
I like it. Now I'm becoming a scientist,
Yeah.
biologist. I don't know.
Yeah.
Well,
Very
this other article, and I don't know that I don't know if you might have heard of this. I mean, you're Dr. Mckellop. But this other study I read says that arterial calcifications on mammograms may be a warning sign of heart disease.
Yeah, so we get a vantage point not only into breast health, but there are other parts of the anatomy. A part of the cardiovascular system has to be within the breast because for tissues to survive, we need blood flow.
Right.
And so we can get a glimpse of blood vessels on a mammogram, but we typically only see them, or we could see them to better advantage when they do calcify. So unlike those calcifications that I described developing within the lumen of ducts.
The ducts, right.
The calcifications associated with arterial calcifications are so-called intimal calcifications. These develop in the wall of the artery. Okay. So you can distinguish them on that basis as well. These are different tubes that are, coursing through the breast. These are blood vessels coursing through the breast, as opposed to the ducts that we had just mentioned. So intimal calcifications can develop as a consequence of cardiovascular disease. This can be a combination of, long-standing high blood pressure, high cholesterol, diabetes, the things that contribute to the nation's biggest killer, which is heart disease or cardiovascular disease.
Yeah.
So when we scan a patient and do an X-ray of their breast or do a mammogram, we could potentially get a snapshot of the patient's cardiovascular health if they do have arterial calcifications on the mammogram. And we see it from time to time. We see it in patients, in the elderly, not uncommonly. But if we see it in young patients, that could be a sign of early atherosclerosis or potentially even diabetes, which can predispose to early onset of cardiovascular disease. So it is something important to note.
Yeah.
And we can be opportunistic in this. Our primary goal is diagnosing breast cancer through breast cancer screening, but having that vantage point of the cardiovascular anatomy, the little vessels running through the breast, then we could potentially glean some information from that.
Yeah, that's really amazing, though, that, it's another reason to get a mammogram.
Yes, absolutely.
Right? So speaking of age and mammograms, so it does seem that incidence of breast cancer in younger women has been increasing to some degree.
Yeah.
I would say you hear about that more and more.
In fact, it has been increasing across the board, and it also includes younger women.
Yeah.
For the past several decades, we've seen a steady uptick in the rates of breast cancer. Fortunately, thanks to breast cancer screening, the mortality or the deaths associated with breast cancer have been decreasing.
Okay.
So despite this increase in the incidence, we have been fairly successful at diagnosing disease early and at a treatable stage. So women, fortunately, are dying less frequently from breast cancer, thanks to improved treatments, but namely to successful screening. And for that reason, I would encourage patients to continue getting annual screening. If you're average risk, starting at age 40 and potentially sooner, should you have a family history or a genetic predisposition. Right.
Yeah, I mean, it's all about early detection.
Absolutely.
Because it's pretty treatable if you can catch it.
Yes. We don't have a cure per se for breast cancer, but we have something tantamount to a cure, which is early detection. When you find disease sooner at a smaller size, then it's more treatable.
Yeah.
And breast cancer screening has shown up to a 30 or 40% reduction in breast cancer related mortality. So a lot more lives are saved when women adhere to a screening program.
All of this, I feel like, comes full circle when we talk about like regular screening and 3D mammogram and breast density. All comes back to how to improve mammography, right? And make it even, better and more succinct or whatever. So there's new technology that, definitely it's evolved from 2D mammogram to 3D mammogram, but now there's even a further step you can take.
Absolutely.
Which is a program that we have here called EBCD, Enhanced Breast Cancer Detection. So maybe you could talk a little bit about that.
Right. So EBCD is the latest evolution and the razor's edge in terms of technological advancement in terms of detecting breast cancer. At its foundation or its core is artificial intelligence. And, we've been fairly progressive and aggressive in terms of pursuing artificial intelligence technology and applying it to our mammographic screening paradigm. And it's been a very powerful utility, and I see it and I use it on a daily basis, and I see the strength of it.
Yeah.
And we may have been the first in the industry to deploy it in the way that we have, and thousands of patients to this point have benefited from its use. So basically, at its core, artificial intelligence looks for features of breast cancer as I would as a human being. Mm-hmm. It's working in the background. It works almost instantly. It's something that I can toggle on and off. It's a co-pilot. It's not an autopilot. It's not taking me out of the driver's seat in terms of dictating reports or anything like that. But it's an assist to me. And it truly is kind of a synergistic relationship that I have with this algorithm in terms of my pursuing or searching for disease. And the way that it works is not unlike the way that my own eye and mind work in terms of finding features of breast cancer. I'm looking for some of these things that we've discussed. I'm looking for calcifications. I'm looking for, architectural change or distortions on a mammogram. I'm looking for masses. Right. This can be done in an algorithmic way, just as, your smartphone can detect your face in pictures and, catalog or create a collage of images of specifically your face.
Right.
Breast cancer can have a classic appearance on mammography. So why wouldn't you want an aid, help in the form of this computer algorithm to identify those features? And that's kind of how the core of it works. But much more than that, not only does EBCD provide the artificial intelligence support to image interpretation, if there's ever a discrepancy between what my thoughts are on that mammogram and the interpretation by the artificial intelligence algorithm, then that discrepancy is resolved by yet a second user, another human pair of eyes, to resolve that discrepancy and decide whether or not there's disease present or not. So it's EBCD, or Enhanced Breast Cancer Detection, is a workflow that employs both artificial intelligence and extra pair of eyes to scrutinize a mammogram to make sure that we're making the most precise diagnosis that we possibly can.
Yeah. So it really is like having multiple eyes on your mammogram. And I mean, it's really precision imaging.
It really is. And, the decision from my vantage point is almost a no-brainer. Why not have that additional... Right.
Because it is an out-of-pocket fee right now. It's not covered by insurance.
Right. As we had discussed previously, prior to this podcast, that evolution from, the prior state of existence, namely in the 2D world to the 3D world, saw a very similar transition.
Right.
Women initially had to pay out of pocket to get their 3D mammograms. And the benefit was quite clear. I witnessed that transition as a radiologist, and I saw the benefits to getting those 3D mammograms. And eventually, insurance carriers had to, support or cover, the expense of this new technology, and they ultimately did. And now we're seeing an additional benefit to artificial intelligence into the EBCD program, and hopefully that same evolution will happen with artificial intelligence. And insurance coverage.
Because it really, we know of cases where it seems to have been an assist.
Yeah, and that's putting it lightly. We've seen a 20% increase in cancer detection compared to where we stood previously, and that may be potentially greater or at least equivalent to that evolution that we saw from 2D mammograms to 3D mammograms.
Right.
So we're detecting more cancers as a result of deploying or employing this EBCD technology.
Right. And that's what it's all about, is catching it early, and all these other things we talked about, the density, not returning after a false positive. All of these things kind of like fold into this one program that can,
Yeah, absolutely. It's not an easy, it's a very challenging exercise making a diagnosis. And as we discussed, we don't exist in a black and white world.
Right.
It's an unforgiving shade of gray.
Right.
And we need all the help that we could get to sift through some of this ambiguity.
Right.
And artificial intelligence and EBCD has come to help.
Right.
Reinforcements are on the way, and EBCD is here to help for sure.
Yeah. That's awesome. That's great. And I know that like some people get, nervous about AI. I think it's still kind of, intimidates some people, or they don't understand, or they think it's going to replace the doctor. Or like, people would be like, I don't want a computer reading my mammogram, but it doesn't work like that.
I am such a person, actually. I'm nervous about artificial intelligence, but I do feel fairly fortunate to be in a field that has been in the crosshairs, for better or worse, for AI development and research. And I see firsthand the benefit of it. And I think ultimately society will benefit from artificial intelligence. And even my personal inclinations notwithstanding, I think we do have to embrace it and all of the benefits that it will confer in the future.
Yeah. Amazing.
Yeah.
That's awesome.
Well, thank you so much for
this
opportunity. Yeah.